Very good evening, viewers. You're watching this special broadcast at 6 p.m. I'm Suesha Sawant, and every evening at this time, we take the COVID questions sent in by you. Today, we'll talk about black fungus or mucomycosis and why cases in India are on the rise, how it can be treated, and what are the do's and don'ts and early signs that you need to recognize. Joining us on the broadcast is a very special panel of guests. I'd like to introduce them. Dr. Jaleel Parkar, he's a pulmonologist joining us live from Mumbai. Also, Dr. Pawan Ojha, senior neurologist from Fortis Hiranandani Hospital in Vashi, joining us live from New Mumbai. And Dr. Shikha Gupta, she's an assistant professor, Eye Department, AIMS, joining us live from Delhi. Very good evening, doctors. And of course, the concern these days is black fungus or mucomycosis. Dr. Parkar, if I could first come to you to understand what causes black fungus and why are cases in India on the rise these days?
It's a good topic that you have chosen for today. Though late, never too late, I could put it that way. It was around 6 months back that I was talking about this fungal infections that would take place in COVID patients who were pumped in with steroids left, right, and center. And it's been nearly more than 6 months that I have been saying so. I'm happy that everybody has awakened to this. Never too late. But I think we have pumped in so much of steroids that most of our patients are having complications of steroids, which come down 3 months, 6 months down the road. The situation is such that every general practitioner has been giving steroids. And naturally, when the patients come with moderate and severe COVID to hospitals, we have to pump in steroids to them. Now, my problem is that when we are giving steroids, one would say as to did the medical fraternity did not know about it? I would say that when we started giving steroids, because I was also a victim of COVID and I also took steroids for myself, and so have many of my colleagues. But at that time, most of the medications were not available, you see, or COVID-19 had not evolved. But now, now that it has been evolved, it is time that we realize the implications of, pumping in steroids to most of our patients, in which I think we were not judicious enough. And now we are seeing the reflection of the same as a side effect, which is called as Mucomycosis, which is very difficult to treat, and it is also life-threatening. My take on this is that we should have all the weaponry available in regards to the treatment of COVID, which we are not. We are flip-flopping. There was a time remdesivir was shortage. There was a time even tocilizumab is not available over here. Plasma has become obsolete. So what were you left with? You were left only with steroids, blood thinners, etc. So if we clinically evaluate the patients at an appropriate time without any delay, and if we give a combination of medications to the patients to see to it that they do not go on the ventilator, I think we would turn around the patients quite well and the patients would go home within a week or so. The number two is also the, through WhatsApp, chats, media, etc., everybody recommending take this steam, that steam, and, the gadgetry for taking up steam, etc., if that is not sterile, naturally you will get, the fungus gets an environment which is very conducive to growth. And that is what is happening. And now we are seeing to such an extent, I think in major hospitals, if you are seeing there are, I'm talking about major hospitals in Mumbai, and so must be in other cities also, that this fungal treatment has been going on, and patients from various nooks and corners of the cities, satellite township, etc., are coming to hospital to get treatment for this, and they have to undergo surgical procedures. Along with that, the antifungals that are going on. So I would say that please let a physician who is on the front, who has been seeing patients day in and day out for the last 1 year, let him decide what is the best modality of treatment rather than sitting across boards and saying this should not be given, that should not be given, and now we have landed up with these effects of steroids, and we are facing a problem with this mucormycosis, which is rampantly now affecting most of the patients. So please leave it to the physicians, and please, the physicians who are seeing these patients for the last more than a year, I think they also have evolved in the modality of treatment. The patient, when we have a look at them, we know who's going to go on the ventilator, who's not going to go on the ventilator, who requires remdesivir, who requires tocilizumab. Why are we flip-flopping about tocilizumab not to be given, then to be given, remdesivir to be given, then does not change the mortality? Now, all these people who are saying this, I would like to know then what is the treatment you all are having? We are talking about mutations, you are talking about third wave, fourth wave, agreed. But show me a change in the modality of treatment. Is there anything that we have concrete? No, we don't have. So why are we keeping on? On the contrary, what we can do, we should do. For example, if we can avoid the steroids, please avoid it. That doesn't mean that, you should not give remdesivir or you should not give tocilizumab. That's not on, and I don't agree to this. And I think people for the last 6 months were saying that I was talking off my hat about this steroid therapy. But now it has come in the forefront, and I think this should be an eye-opener, and we all should see to it that we judiciously use steroids rather than pumping in every patient who comes into the hospital. Correct me if I'm wrong. My colleagues are there. Dr. Pankaj is there. Dr. Shikha Gupta is there. And
Yes, absolutely. You do make a very valid point, Dr. Parker, and unfortunately, that is the bitter truth that, there is a lot of ambiguity when it comes to a very concrete treatment on COVID-19. Dr. Ojha, if I can come to you, because wanting to understand, like doctors are saying, that it's not like mucomycosis didn't exist earlier. It's just that after COVID-19, the cases are on the rise. Is it contagious? How many days after recovering from COVID-19 or during that one can start seeing signs of mucomycosis, recognizing it, and what are the precautions to be taken?
You rightly pointed out that this mucormycosis was present even earlier. So what has changed in this pandemic is basically that it's an opportunistic infection. That means when your body's immunity goes down, then there is a chance for the mucous spores to germinate inside your, nose, sinuses, and then they sort of travel backwards, upwards to the eye, sinuses, and sometimes up to the brain. Of course, the other places also like skin and other organs can also get affected. So first we need to understand that this fungus is an opportunistic infection. That means that it uses the opportunity that you give that fungus. Right. Now, what is the opportunity that we gave the fungus? The opportunity is that most of the people who will get this kind of an infection are not the normal people. First, a set of people who are uncontrolled diabetes. Second, the ones who have had either a cancer chemotherapy or someone who is taking a medicines to suppress the immune system, that is immunosuppressant, in case of organ transplantation or many other, chronic illnesses, sometimes we give steroids. So more or less, this is the subset of patients that will get this opportunistic infection. Now, what has changed in this COVID is that when COVID affects you, it creates an atmosphere that sometimes there is an activation of the immune system. So you want to suppress it with steroids. So there are a lot of these immune-mediated diseases that come. And in that time when you want to suppress this by giving steroids, there's a lot of inflammation happening in the body, or tocilizumab. In that situation, you create an atmosphere that the immune system goes down so much that now the spores, they become active and invade the system. So this is what has happened. And part of your question is how to recognize that. I'll take the last question first. So when you sort of identify that this patient has had a mucor, then one has to act very, very fast. So how to identify this is a real task. If you know, the most common type of this mucormycosis is called as a ROCM, that is Rhino, Orbital, Cerebral Mucomycosis. That means it is inside the nose, inside the sinuses, that is Rhino. Orbital means it's inside the eye or in the socket, and from there it goes up to the brain. So Rhino, Orbital, Cerebral. So one can imagine that the earliest stage will be when the eye becomes red or swollen, or there is a tenderness around the nose, and then there is a swelling of the eye is protruded outside. There is sometimes nasal discharge, which can be red, or there can be a blackish discoloration of the eye around the nose or in the hard palate. You look inside the mouth and you see this. Some of these patients, it invades so fast that they also develop stroke and lot of black gangrenous mutilation. So that is why it is called as a black fungus. So these are the ways in which one must identify. However, at the earliest stage, if someone is having a pain around this region, redness, swelling, or numbness, then that must be the first instance of contacting a doctor urgently. And now we have made COVID in this COVID scenario. We have made mucor teams. So this is called as a code mucor in hospitals, wherein many departments, they come together, starting from the ENT specialist, then ophthal, neurologist, maxillofacial surgeons, pulmonologists, they all, and the intensivists obviously. So they all come together at once, and we have created groups so that when there is a patient, everyone is notified immediately, and then everyone can put in their opinions and make the best plan and take it forward. So, and the final question that you asked me is, when do we suspect that when is the time that the COVID patient can get this fungal infection? So we have seen at the earliest when the patient presents with COVID itself, like maybe day 3 or day 4 of COVID, patient is still in the hospital, and then you give steroids and diabetes is already there, and there is a signs of this mucor coming up. Whereas we have also seen patients who had COVID last year, maybe in April, May, and they were stable all the while. And during the last few months, they have sort of left over the control of diabetes, and so that's how they have got mucor. So it's even 1 year later after COVID that is possible. So most important factor are use of steroids, a diabetes which is not very well controlled, and patients are not taking precautions, as Dr. Parker already mentioned. So these are the points that I wanted to make very clearly.
All right. I want an extension to that answer, for which I'd like to go to Dr. Gupta now. Dr. Gupta, firstly, to understand from you that those who are developing mucomycosis, what are the risk factors involved? Are particular age groups more at risk, being the youth or being the elderly age group? And also, are the family members equally at risk if somebody is developing the black fungus? Are the family members immediately to stay away from the patient?
So the question is good that unlike COVID infection, the mucormycosis is not contagious. The mucospores are already present in the air, and the most important criterion for developing mucormycosis in any patient is immunosuppression. As Dr. Oza has already mentioned, that the immunity has to be low when the fungus invades because it's already there. So it's not that if somebody gets in the family, the others will also get it. It's just that immunosuppression, and mostly it develops after the patient has recovered from the active COVID infection, or even during COVID if the patient has a prolonged course and the patient is on high dose of steroids. So the two factors that are being postulated that why the mucormycosis is on the rise these days, unlike during the first wave of the COVID last year, it is because first thing is rampant use of steroids and sofosbuvir also, which is an immunomodulator. It also works to decrease the immunity of a COVID patient. The other thing is the industrial oxygen could be a factor in this, that it is not sterilized oxygen that has been being used in the hospital so far. So this is unsterile oxygen and it's going through the pipes. But there are certain, and there's a lot of panic in the population right now. I would like to stress here that there's no need to panic. It's not that every COVID patient will get it. It's only that if you are immunosuppressed, you just be careful that you keep noticing any changes that might take place over the few days, especially during the first 6 weeks of contracting the COVID infection. That is the most crucial time that you should be aware that, okay, if I'm immunosuppressed, I have taken large doses of steroids, or I'm a cancer patient, or I have had a transplant and I'm on immunosuppressive therapy, that, okay, I am immunosuppressed and I should be aware of all the symptoms and signs. It's already been mentioned by Dr. Ojha that there will be some paresthesias or hyperesthesia on the nasal region, because it starts from the nose region. The spores will be inhaled through the nose first. So there can be local swelling. There could be bad smells. Unlike the anosmia that is seen in COVID infection, where the patient is not able to smell, in mucormycosis, it gives you foul smell, dirty smell that the patient might be having. Then there could be localized swelling or pain if it invades the sinuses. It could go through the dental region, to the palate. There could be pain. There could be irritation in the nose. The patient might feel that I want to tickle my nose more frequently. There could be some discharge also, some mucoid discharge, or blackish discharge also if blood vessels have been eroded. So these are the things. So there are certain precautions that the patients can take, follow, and they would be safer than the usual population. So first thing is that you have to keep the nasal hygiene very well in place. You should be doing, even now the patients are also on inhalational steroids. So that also goes to the throat, and sometimes the patient may be using nasal steroids also. So these are all risk factors that it is suppressing the normal flora of our body. That is a very important risk factor for fungal invasion. So it's very important that after you are taking steroids, inhalational steroids also, you gargle thoroughly. There is no leftover steroids on the tongue coating, there is no coating. Also, it's important that you keep gargling. You can do betadine gargles also. There are betadine nasal sprays also available of 0.5 concentration that you can do nasal sprays. And you should be thoroughly cleaning everything. If you are on home oxygen therapy, you should be cleaning your tubing very, very thoroughly, that there should be no infection, no spores that may be there in the tubings, plus the water that we use to mix the oxygen with. That should be distilled water in the humidifier. That is also a risk factor that could, invade the already immunocompromised tissues of the patient. And of course, there is no need for the patients, the relatives or the family members to stay away from the patient. So you should be very aware, and if you suspect that you might be having some mucormycosis symptoms, you can have an endoscopy done by an ENT surgeon who could actually tell you that there is a lot of panic, there is more of panic, and you're not having this. But still, it's important to be aware, then not aware, being aware and getting the infection spread through the whole of the Rhino or Orbital system.
Right. Dr. Gupta, if I can go to Dr. Parker next, because Dr. Parker, you also mentioned steroids and overuse of steroids that can lead to mucormycosis. But given where we stand in India at this stage with COVID-19 and how severe the second wave has been, what is the severity of mucormycosis? What is the stage when one can treat it at home and probably follow the precautions and do's and don'ts that Dr. Gupta just mentioned? Once hospitalized, what are the chances? Does it lead to death? Can it cause death? And what are the treatments available at this point?
See, the treatment available at this point is to use antifungals, which are also rhinotoxic. So you have to understand that when you are using antifungals, again, they are rhinotoxic, so the kidneys have to be taken care of. There are surgical procedures like FEST, etc., where they go into the sinuses, clean them up. Sometimes you have surgery in the brain that is also being done by the neurosurgeons. So there are various procedures. But you are not left with much of the options. You will have to use antifungals. You'll have to see that proper sterile, hygienic conditions are met with. You will have to see that the oxygen that is given is also not oxygen that is causing more harm, which gives a fertile environment for the fungus to grow. So we don't have much of the options. If you're talking about the fatality rate, yes, the fatality rate is also quite high. So I think we must see to it that we don't come into a stage where the mucormycosis is already sets in. So it would be very prudent and diligent enough if we start the treatment appropriately and we nip it in the bud before the mucormycosis sets in. Because if the mucormycosis sets in, then you are heading for trouble. Even though the patient has recovered from COVID, because of mucormycosis, there are various other complications which are also very death-threatening. So you have to see to it that the patient who comes to you, you treat them diligently, very prudently, taking into consideration everything from his immune status, from his clinical status, from the lab investigations we are supporting, his ventilator requirements, etc. Rather than being rash about it, let us be very prudent and see to it that we don't reach that stage where mucormycosis sets in, because it's very difficult to treat. Let us take it with a pinch of salt. We don't have much options, and I think we should have spoken about this steroid a couple of months back, but we did not do that. And I think never too late. Let us talk about the steroids. Why should we wait for the mucormycosis to be an advent into us talking about steroids? We should have spoken of about the ill steroids much earlier, which I think we did not do. And that is why we have landed up with this. And secondly, let all the weapons that you have to treat COVID, though they are limited, let those be available. Let there not be a panic situation. Let us not create, views into the minds of the population about the scare, about the treatment, about the COVID mucormycosis, etc. Let's not do that. Let us be very judicious in all these issues.
Right, right. If I can take that same point to Dr. Ojha, because Dr. Ojha, like Dr. Parker has said, that the use of steroids is really under question. Discussions are also underway when it comes to giving plasma treatment and whether it should be dropped. Now, certain treatments that are being used in India are not being used abroad. What I want to understand from you is, at a point like this, when we see that cases are on the rise in India of black fungus, why is it? Is it also because of the ambiguity in treatment? Do we need to reconsider? Are we still testing the waters in a lot of ways? And will we see changes given what we are seeing today? The rise in mucomycosis cases and the treatment and its effectiveness, even in COVID-19, be it plasma therapy, be it the use of steroids, remdesivir, etc.
So these are very nice questions. I would say that pretty much unanswered, speculative. But, I will agree with Dr. Parker in saying that, we need to understand what is the substrate of these infections. So if you look at the overall picture, then let us say that if we have 1,500 cases of mucor till now, maybe, but we are having like 3.5, 4 lakh cases every day. So it doesn't say that this has increased like rampantly, but this is a point of concern just now. So those patients who are being treated in larger hospitals with better facilities, I'm very firm in believing then that more protocols and more decision making is being followed amongst them, and there may be a lesser instances of mucor. So, like in the hospital in which I work, we have been following precautions and also giving some kind of an antifungal prophylaxis when the patients are discharged, home. So you give them some tablets for some time, and most of these patients, I would say almost none, have had a fungal mucormycosis. So, and also we keep a very strict tab on their sugar controls, the use of steroids. So, it's much more to do with how you treat patients and how you educate them to take it further. So that is the most important point. And there this season what we have seen is there are a lot of mutants. So the way the virus is behaving is probably different from what it was behaving last year. It may also be doing something more to the immune system this time, and that is why there may be a turn of events in favor of mucormycosis. So, but nevertheless, we need to make stricter protocols as to how and when to use the steroids, how to track our patients with diabetes so that they don't fall into that trap of poor control. Because everyone is trying to help them and people are telling that you take this, you take that, you take fruit. So the last patient that we had, he had very nice control for like 10 months, and only 2 months some of his relatives kept on feeding him fruits, even though he's diabetic. So his sugar control went out of the window. So, in trying to help these patients, sometimes we may be doing more harm. So, it's our duty to educate these patients, track them, and tell them what is to be done. So, if we do all these things, let's not only blame remdesivir, let's not blame only tocilizumab or steroids, but if those patients who have taken these or immunosuppressants, but they are not having diabetes, the incidence of this mucormycosis is very, very tiny in these patients. So, the first group of patients is the ones who are the ones having an uncontrolled diabetes. On the top of that, they have had a bad COVID infection, they have had use of steroids, they have had other immunosuppressants, and then their sugar control and hygiene is not good. So this is the substrate, and these are the patients we need to sort of counsel them carefully and track them nicely. At the earliest hint of infection, we must call them to the hospital. We should give them a window where they will be able to,
Right.
catch us. Yeah.
Gentlemen,
Approach
these
us,
have
I
been
would say.
very, very valuable inputs, and I'm really running short on time. In fact, I have to wrap the show very fast. Dr. Gupta, if I could quickly come to you in the end and an answer from you in brief on the do's and don'ts for mucormycosis that one needs to be very careful about.
So I would say that do not be in a panic mode. Do not stress, because that also helps to decrease the immunity. It's a good factor for the fungus to grow in your body. So be happy. Keep enhancing your immunity as you can, and keep your sugars under control. So HbA1c is a very good way which can tell you how your sugars have been the past 3 months. And you can also get your sugars tested in between. So if you are diabetic, be sure that your sugars are controlled, and if not, consult your endocrinologist at the earliest. The second thing is steroids should not be used for too long and should be started only after 5 days of contracting infection. Only if there has been some kind of inflammation, your breathing has deteriorated, or your CRP score is high in the blood test, or CT scan shows a high CT score. So these are the indicators of starting steroids. And of course, you have to keep gargling with betadine. There should be proper mouthwash. Keep your hygiene maintained, and beware of the symptoms. Keep checking of all these symptoms: some hypoesthesia, some redness, some irritation in the nose. So it will start from the nose when in the beginning, and consult your ENT specialist, consult your doctor. That is very important, that you should have a good relationship with your doctors. Keep checking with them whether you could be having at small symptoms, especially if you are immunocompromised. So, and the most important thing is have faith. It's not that you will be the one who will contract the infection. So be aware, but don't be in a panic mode. That's my take-home message.
Thank you so much, doctors, for educating our viewers on black fungus or mucormycosis. Very unfortunate that cases are on the rise. And as much as we can learn and follow and be careful is the mantra at this point. Thank you very much once again for speaking to Republic.